Okay. So look, thanks. Sorry about the bit of mix up there at the start. I know you can't see us on video, but hopefully you can see the screen okay. So look, welcome to our talk today on making ISC, intermittent self-catheterization, a success. Braun are here to help. It's an educational webinar. My name is Niall Ryan. I'm with Braun, and I'm joined today by Maeve Williams, urology CNA, clinical nurse specialist, spinal bifida and urology in Temple Street Hospital. Maeve is just going to talk us through today the journey of the spinal bifida child through paediatric services and transitioning into adult care. So Maeve will roughly take about 45 minutes initially to talk through that side of things. And then I myself will talk, with the help of Roz, we'll talk through Braun's ISC product offering, and Roz Cheshire then as well, our own clinical specialist, who I'm sure a lot of you already know, just going to delve a bit more into the clinical service offering we provide as well. So look, I won't delay it any further. That's just a bit of obviously etiquette and online meetings. We're all well used to webinars at this stage, but we can't really talk on that based on what's just happened. But look, I won't delay any further. I'll thank Maeve very much for joining us today, and I'll pass you on to Maeve now. So thanks a million.
Okay. Hello, my name is Maeve Williams. As Niall just introduced me there, I work in Temple Street as a spinal bifida urology clinical nurse specialist. My talk today is going to be on the urological care of a child born with spinal bifida, their journey through Temple Street from birth to 16 years. My role is really to look after any of their bladder and bowel problems that they encounter throughout their period in Temple Street. So just to give you an overview, on average about 95% of children born with spinal bifida, that is both the open and closed, will require some sort of care, intervention and assistance in dealing with their bladder and bowel issues throughout their life. For ease of this presentation, I've broken it up into different ages and stages. So as you can see from the slide, we have the newborn stage, 3 months, 4 to 6 months, 9 to 12, 24 to 36, 4 to 5, 6 to 8, 10 to 12, and then 14 to 16. This is in line with when our children will be accessing what we call our spinal bifida multidisciplinary team clinic. Ordinarily, we would like this clinic to run yearly. That will be the gold standard, but unfortunately, with the absence of enough consultants, and obviously now with COVID, these are running a little bit later. So we are seeing our children at the moment every kind of 22 to 24 months. We're hoping in the next year or so to have a new consultant on board, and with that, we would like to achieve our children coming to the multidisciplinary team clinic every year. And in this presentation, we are particularly discussing about myelomeningocele. So the myelomeningocele is when the spinal cord itself is involved in the defect. And thankfully, over the last, I suppose, 10 years or more now, with the antenatal diagnosis of most of our myelomeningocele patients, parents are offered antenatal counselling where their bowel and bladder issues are explained. Education will then have gone on to research the neurogenic bladder and bowel, which following from their birth makes education of their baby education about their baby's bowel and bladder issues less overwhelming for them. When the child is transferred over to Temple Street, there's a few things that we would see which would kind of indicate to us that we would need early supportive care and interventions. One of the things we would see would be what we call continuous dribbling. It's when you open the baby's nappy that they are dribbling more or less every time you open the nappy or if you move the child. This would indicate to us that the child may have what is called sphincter incompetence. And that would be when the muscle that is normally opened and closed from nerve supplies from the bladder to the brain, when the child needs to micturate, isn't working properly. This would indicate to us that there's a deficit in the nerve supply from the defect down. And this would normally affect your bowel, your bladder, and your legs. Another thing we would see is a child may have a distended bladder, so basically the bladder looks very swollen from the outside. This would indicate that there's some sort of an outflow obstruction and that the child could be have incomplete emptying. So again, it's where the sphincter muscle isn't opening and closing efficiently, may open but close quickly, and there is some urine left in the bladder. We then would see in some of our children what we call an expressible bladder or positional dribbling. So if you were to sit the child upright, they would wee. If you were to move their bottom, they would wee. And then if you were to palpate the bladder on the abdominal area, that they would wee as well. This is another indicator of your neuropathic bladder. Need for intervention is determined by a consultant urologist from his research and experience, combined with the clinical findings and diagnostic test results of each individual child. As discussed earlier, 95% of children with the open and closed need some sort of care intervention. We would find more or less 100% of our children with myelomeningocele would need care intervention for their bowel bladder throughout their life. This is just a picture to show you what I meant by the spinal cord being involved in defect, and this is what we would call an open myelomeningocele, and that's a young infant with the myelomeningocele. Then to start off with, we have what we call the newborn stage. So the child is sent over from the maternity hospital. We would, on admission to Temple Street, obviously there's a lot of people who are involved in your child's care. So from my perspective, from the urology perspective, we would, at a time that's convenient in the first few hours of life, we will place an indwelling catheter. What I mean by the indwelling catheter means it can stay in for a period of time, as opposed to your clean intermittent catheterizations, which is only for a short period of time. The indwelling catheter is left in pre-surgery. We then would do baseline bloods to assess the child's kidney function. We have a renal ultrasound done. I have written here a clamp indwelling catheter for 2 hours. That's just so that we have the bladder is full for the actual renal ultrasound, so we can get a good picture of both the bladder and the kidneys. So we have what's called a baseline for further treatment later on in the child's life. You would then meet, the parents would then meet myself. I call myself the CNS for the rest of this talk, because it's quite a long-winded title. We would meet briefly in the first day or two, just to go through some written advice, some verbal education. But obviously, during the first 5 days to a week in their child's lives, there's a lot going on. So we would keep our conversations and our interactions quite short at this stage. But obviously, at each time we would meet the parents, we would offer our education and training at that point. And then in around 5 days post the repair, depending again on the child's condition, whether the wound is healed, whether they need to go for a VP shunt, we'd remove their indwelling catheter. At this stage, then we would commence the clean intermittent catheterizations, providing education and support. For the clean intermittent catheterizations, a parent is taught from the offset that it is done under clean technique, and obviously their hygiene practices are very important. In the hospital setting, we do it as a sterile technique, but the parents in the home setting and themselves in the hospital setting do it as a clean technique. They wash their hands, the baby is cleaned down at least 3 times with just cool boiled water or water wipes, nothing with any sort of product on it. And then the parents are taught how to pass the catheter into the bladder. It takes a number of sessions with the parents to go through this CIC training. And we, over the period of sometimes 2 to 3 days, sometimes up to a week, we would demonstrate to the parents, teach the parents, observe the parents during the catheterizations, and then when they feel confident, we would deem them competent to do it on their own. But also throughout this time, we were to give them continuous support, and if they need us to come back and stay with them at any point through the catheterizations, we provide that service. We then also commence what's called prophylaxis, which is just a nighttime small dose of an antibiotic to again prevent possibility of any infections. In the early newborn stage 2, we do what's called emptying studies, and this is basically to see how well the child is emptying their bladder at this point. Again, it's all baseline for our future care. We would do what's called a pre-void bladder ultrasound. We're checking to see how much urine is in the bladder. We fit what's called a nappy alarm, which is just a tiny little disc that we put into the nappy, and then the alarm will go off, and we're there to do what's called a post-void bladder ultrasound, and that will determine if the bladder is emptying fully. We'll be able to see how much volume is left behind. This helps parents greatly to understand the reason for doing the clean intermittent catheterizations. At this stage, normally children and babies are emptying their nappies. They're still having wet nappies up to about the age of 2, but they may not be emptying their bladders sufficiently to avoid infections and to avoid possible kidney damage. We would this is the main reason for commencing this clean intermittent catheterizations. We also would book what's called video urodynamics and renal ultrasound for the 3-month stage. At this point, throughout the period of the week or 2 that they're with us as well, we would discuss the children's bowel patterns, changes in their bowel patterns, and any intervention that's needed. Rarely do you need to intervene with bowel washouts at this age, but we would discuss it with the parents if they're made aware of it, and if needs be, we would commence bowel washouts as well. They would have a social work referral done to apply for their long-term illness card and medical cards and domiciliary care allowance if applicable. On the long-term illness card, our parents, our children are entitled to all the medications, their catheters, and any other equipment that is needed for their care. We ask parents to choose a local pharmacy, and we would fax off a prescription for their catheters and medications prior to their discharge home, so that everything's ready for them to going home. And then a copy of the prescription is given to the parents to give to their GPs should they need or require further prescriptions at any stage. And we can also supply them too if needs be. A public health nurse referral is done pre-discharge, and we would phone them so that the parents have further backup and further support in the community. We provide ongoing parental family education and support. From myself, this midwifery CNS, we give the parents our email addresses and our phone numbers should they need to ring us at any point, for just sometimes for more support or if they want to have further education. Then in around the 3 months, we bring our children back for what I mentioned a while ago, which is video urodynamics. This is a pressure study done with X-rays. The aim of this pressure study is for the early detection of bladder and kidney reflux problems. It involves placing a catheter via the penis or urethra into the bladder for the duration of the study. We instill a calculated amount of a radiopaque fluid in order to assess their bladder function. What we're looking for here is overactivity of the bladder. When we see that, what we see on the screen as we're doing this test is large peaks, which means that the bladder is contracting. We're looking for when they start to contract, if they leak, if the pressure increases during the time, and do we see any reflux into the kidneys. This again is a baseline, but it also gives us an indication as to the condition of the bladder and the kidneys. We would do, at this point, we would do a repeat renal ultrasound, so we have a comparison for the one that's done at birth. We would discuss with the family, was there any previous UTIs over the 3 months? We then have our specialist bladder physician, Miriam Doyle, present for this, and she would look at the previous results and these results, do comparisons and make a plan of care. At this point, if the child happens to have a very overactive bladder, we would look at commencing a medication called oxybutamine. This is to reduce the irritability in the bladder, thereby hopefully increasing the bladder volume. We want to see that their bladder can expand into a normal oval shape or rounded shape, and hopefully by allowing the bladder to expand, reducing the irritability of the bladder, allowing the bladder to expand, we can decrease the frequency of micturition. And over time, this will help when we're working out how many catheterizations a child would need a day. Next slide. At the commencement of doing CICs, we would ask parents to do possibly 2 to 3. And the reason for doing that at the early part is to make sure that they have points in the day where their bladder is emptied sufficiently, so we don't have what's called stasis or pooling of urine that could possibly cause infections. So as the child is getting older, and really depending on the results that we see as well, and the renal ultrasound and the video urodynamics, we would look at increasing the number of CICs per day, so possibly up to 3 or 4. We would change the prophylaxis as per their weight, and we would look at sizing them up with their catheters as well. At birth, we would normally use a size 6, so at this point, we would look at using a size 8. The prescriptions then are given for the new doses and their new medications. We do a detailed discussion on the child's bowel habits, looking to see do they need any stool softeners added, such as lactulose. One thing we would note to the parents is oxybutamine can cause constipation because it can cause the body to lose more fluid. So we would look at discussing what their bowel motions have been like over the last 3 months. Normally at this point, your child is still on their milk feeds, be it breast milk or bottled milk. So you would expect the stool habits not to have changed too much, but you can have some changes. So we would recommend introducing the stool softener, and maybe just once a day, maybe to give them the 2 ounces of cool boiled water to help with their fluids as well. Parents are given time during this meeting with us and this testing to discuss any of the issues that have arisen over the past 3 months, and both Dr. Doyle and myself would make a plan to help alleviate some of them. We then offer, if parents need be, to come back to us in our outpatients clinic at a time that is really suitable for them and ourselves to discuss more issues that have arisen over the last 3 months. Then in around the 4 to 6 months, our children access what's called our spina bifida multidisciplinary team clinic. This is where I've kind of divided the timings up into, because in this clinic, the parents will see ourselves, they will see their pediatrician, they'll see their consultant neurosurgeon, they will also have access to the physiotherapist, they'll have access to our psychologist, and also to our social workers and our spina bifida nurse as well, if we get present at that clinic. So in this clinic, it'll be the first time usually that the parents have met the consultant urologist, Mr. Cascio. He would look at the testing that we have done over the previous 3 months, make decisions on the need for further testing. Other tests that we would do to check the kidney function would be things such as DMSA scan. This looks really to see have the kidneys had any damage done to them since the first scans and the one at 3 months. And we would particularly do this scan if the child has had repeated urinary tract infections since birth. A plan of care then is discussed, and the parents are involved in this. We would look at what we call their bladder diary. Every time they access our clinic, we would send a bladder diary out to them for parents to fill in. This is a diary that they fill in over a period of 3 days. It gives us a snapshot of what their fluid intake, their bowel motions are like, and what their urinary output is like for the 3 months. You can see here to the right and the Bristol stool chart, and what we like to see with our children is a stool type like 4 or 5. Stool type 1 would be a constipated stool. They would need intervention for this one. Stool type 2 would be the same, a constipated stool, sausage shaped but lumpy. Stool type 3, we could probably just increase their water, and in time of they're older, change their diet to a more high fiber diet with type 3. But these 3 we're looking at as constipation and signs of constipation. Type 4 and 5 are good. Type 6, possibly they have too much laxatives or they're too much of a high fiber diet. We'd look to change things a little bit there. And type 7 would be too watery. Type 7, if a parent indicates that the child is having watery stools all the time, at the back of our minds, we would think of impaction as well. So these are all what we're looking at. So that's, as I say, the bowel pattern and consistency discussed at length at that clinic point as well. At this stage, we would possibly be talking to the parents about commencing bowel washouts. And at this age, in the 4 to 6 months, we would use a syringe and catheter. And normally we'd use about 10 to 20 ml per kilogram of saline for their washouts. During the clinic time, if possible, we would start the education. If not, again, they can come back to us at a time that's convenient in the next few days to start the bowel washouts. And again, the laxatives as well, such as lactose. This would all help with their constipation. The dose of medications needed are adjusted then for their weight, and an updated prescription given to them. We then would start discussions in around a weaning diet. As said earlier, a high fiber diet and a high fluid intake are very important to try and prevent constipation and to keep our kidney function healthy and well. So at this clinic is a good point for the parents again to ask us any questions around that. We could again provide literature, but as we know, a lot of information is now available on the internet for the parents around a good high fiber diet. We would emphasize to the parents to avoid the likes of rice and rice-based products, and look to, if possible, to use just fruit and vegetables, pureed fruit and vegetables when they're weaning their children onto their weaning diet. The next time we would see the children, apart from when parents have asked to see us, would be at their next clinic appointment in around the 9 to 12 months. This clinic, again, we were seen by the urologist. We would have a VUD or UD done before the clinic. A video urodynamics is done if there has been a presence of reflux on the first one. Otherwise, we can do what's called standard urodynamics, and they're done up in our department, exactly the same as the video urodynamics, but without X-ray. So we can actually do more urodynamics than we can do VUDs, because we have unfortunately only 2 slots per week available just for the video urodynamics, but we can see up to 3 or 4 children per week to do urodynamics. We have to obviously work out which is needed depending on the child's condition. We would do another renal ultrasound, and then our urologist would look at all the findings. We would look at their bladder diary yet again. findings and comparison of the previous tests are now done, and new testing discussed with the parents. We would change their medications according to their weight for their bowel and bladder prescriptions. Then also talk about their diet and fluid volumes. At this point, we would still expect a child to have at least 150 ml per kilogram per day of fluid. They're still on their milk, so you would like them to be mainly milk-based, but also we would like them to be drinking water and get the child at this point to be drinking water with their food as really a way forward for the children for the rest of their lives, rather than juices or anything kind of juice-based. We would prefer them to have water and then milk. We would discuss and again go over their CIC practices, reiterating really strict hygiene practices that is needed, and troubleshoot any problems the parents have had over the past few months. Again, as I said, they have our phone numbers, they have our email addresses, they can contact us at any time if they have any issues, not just our clinic times. In around the age 2 to 3, then we would do another video aerodynamics and UD pre their clinic and another renal ultrasound. We would throughout this time have ongoing blood results to determine their renal function, and children who have any deterioration in their kidney function will be referred to a renal consultant in Temple Street for ongoing care. We would then at this point discuss a plan for interventions with the parents. If we have a child who has a continuously overactive bladder and we're unable to relax with the oxybutylene, there is a surgical intervention we could use, which is Botox injections. They would come to our day ward, and the urologist is able to visualize their bladder via cystoscopy and inject Botox into the wall of the bladder to relax it. This works very effective. This can be very effective, and we have found over the years it has made a huge difference to our children's ability for their bladders to expand and take larger volumes. At this clinic, then, if the child hasn't had any UTIs over the past 2 years, we would take them off their prophylactic antibiotic and give them a trial of it. Again, education on the day around signs and symptoms of UTIs and what to watch out for. They'll be told to send a urine sample to their GP or to ourselves in Temple Street if there's any worries or concerns around a possible UTI. Again, our bladder diaries are reviewed, and plans to change any care will be discussed with the urologist and ourselves, the clinical specialists. Again, in around the age 4 to 5, the children and their parents will again access our spina bifida MDT clinic. We will then do a UD or VUD as indicated by our consultant prior to this clinic with the renal ultrasound. We aim to do UDs every 4 years after the age of 2. That would be what our consultant would hope to do. And this is, again, so we can keep a continual observation on the child's bladder and bowel, on the child's bladder and kidneys over their lifetime. The above results will be discussed with our urologist and plans made to change any of our care. We would always do, after the cystic Botox, we would always do a UD 6 months afterwards to see the effect of it. So they may have had a UD again in between, which that would depend on whether the consultant requires it or not. At this age, we're working towards what we call social continence for school age. Some of our children would have started in preschool, and the parents would have looked at getting the child to a point where they could wear a normal pants or with possibly a pad going to school. A way to do this would be to look at increasing the number of CICs the child is doing. We would say to parents to look at doing a CIC in the morning, preschool, at a little break, at lunchtime, once when they come home from school, in around their evening meal, 6, 7 o'clock, and then pre-bedtime. So you're doing about 6 catheters today would be what we try to aim towards to gain social continence for the child going to school. We would then look at their frequency and volume in their bowel washouts, and then their dose of laxatives, again to try and get social continence for when they're in school. We normally tell parents to look at doing their bowel washouts every night before school time, and maybe taking a break at one of the nights over the weekend, because you don't want the child to have accidents in the school day. The SNA then that the child required is applied for through the school, but we in Temple Street will supply supportive letters for their request. All of our children and their families have the support of a dedicated social worker and child psychologist from the spina bifida service in Temple Street. They could be referred to them, or the parents can ask to meet them at any time throughout their years accessing our service. Age 6 to 8 years, they would then again access our what we call our MDT clinic. Our renal ultrasound is done plus or minus UD depending on what the consultant has asked for. We would do bloods to review their renal function and their bladder diary that the parents have filled in, which is a 3-day snapshot of their, as I explained earlier, their fluid intake, their fluid output, and their bowel habits before they come to clinic. This again is discussed and reviewed with the urologist. The medications are adjusted as needed, and then any new issues are talked about. At this point, normally we have parents and children alike, because they are growing a little bit older and more aware. Children may ask along the lines of, how can I start to become more independent with my my catheter and my bowel care? Where possible, we would try and use all medical means to achieve social continence, but sometimes that's not possible. So we would look then at looking at surgical interventions. There's one thing called a mini button, and then a metrophenol is a more of a permanent solution for their bladder emptying, and then an ACE procedure for their bowel emptying. This picture here just gives you a little bit of an idea what I mean by metrophenol. I will discuss it a bit more in the next slide, but this is just the channel that is made here on the right hand side where they can access the bladder, and then the bladder itself is augmented, or shape of the bladder is surgically augmented so that it would actually hold a volume of fluid that is sufficient for the child's age. So any surgical procedures, as we can well imagine, comes with their pros and cons and will only be used when all medical avenues are exhausted and a fully informed discussion is had with the parents and child where appropriate and the urology team. Independence with CICs and bowel washes are discussed, and then this is where all the avenues are exhausted, and then possibly surgical procedures are discussed as well. At this age, parents usually start asking the questions, and it usually can be a little bit older before they would do any surgical interventions, but that would depend on the child's condition. The type of CIC used as well is discussed, and my colleagues here will discuss the types of one that Braun have, but usually parents at this stage and children would like to have a bag collection on their CICs, so that if they are out and about, they don't have to be in a toilet area to do their catheters, and they would still have a clean, closed system that they could use. We can offer it for their continence care reps to go out and support the children at home around their bowel washes and catheters, and they have this support always throughout their lifetime as well. Again, around independence, we would supply literature to the parents and the likes of a mirror so that the child can actually be starting to see what area they need to catheterize. We would start the education, and as I said, involve the continence care reps for their home care as well. And that's just a little picture there to show you what the metrophenol is like, or the child can. That's quite old-fashioned when they catheterize into a jar, but it'll give you an idea that the child can actually empty their bladder from the abdominal area rather than from the urethra. And then to give you an idea what a metrophenol is a tubular structure that goes into the bladder through which a catheter can be inserted to empty the bladder of urine. So it goes in through the metrophenol is like a stoma. Some people would know what a stoma is from the bowels, but a metrophenol is similar to that in that a urologist will take the appendix and connect one end to the bladder and the other end to the wall of the abdomen or tummy. This small opening is used to pass the catheter along the new channel into the bladder so it can be emptied. The procedure of catheterization via the metrophenol is carried out as a clean procedure as well. The next stage we get to then is around 10 to 12. For this clinic, we would send out, prior to the clinic, along with your bladder diary, we actually send out what we call a transition document now. It's the transition document in that we want the parents and child to, I suppose, start thinking about their transition into adult services. The few things that we were looking at is obviously their physical abilities and their physical needs, but also their emotional and psychosocial needs as well. So the parents are sent out this document so that they could read through it themselves. It's a tick box one, and then discuss with their child. Some of our children will be 12 at this point, so they would be, put into the secondary school and looking towards more independence and more knowledge on their condition. And as I said, along with the bladder diary, this document is filled in. At this point, we would then do repeat UDs, again determined from previous UDs or VUDs as the urologist wants, and we're all the while keeping a close eye on the condition of the child's bladder and kidneys. Another renal ultrasound done and compared with previous ones, and their bladder diary will be reviewed. Again, seen by ourselves, the CNS with the urologist, titrating the medications and discussing any issues they've had, such as UTIs, and alter their medications accordingly. Pardon me. Plans to attain social conscience are discussed, and ways to achieve same, both medically and surgically, where appropriate. At this point, the children usually themselves are asking for further help and interventions. So we've started the discussions with the parents, usually around the 6 to 8, and now at the 10 to 12, we find that the children themselves get involved a lot. We continue to provide independence and support, provide support around independence with CICs and bowel washouts. We would bring the children into our department in the outpatients and start the process. Parents are supported at home, both with the subliterature, and they can phone us and contact us at any time for any tips and help around independence with CIC. And then we have our continence care nurses who can go out and help as well. The parents then are also provided support and literature to start their education around the child's sexual maturity for their young adolescents. A referral can be made, or the parents can ask at any stage to see our child psychologist to help with this as well. This is just a picture of a young girl who's an athlete, who's a basketball player, and it just goes to show the independence that our children require and also would strive for. Then in around the age 14 to 16, our children are coming to the end of their time with us in Temple Street. So we spend a lot of time in around their what we call transition to the adult services. We're developing a document which will be like a passport the child will have, and they will start, as I said, back in the age 10 to 12, filling in a questionnaire before they come in. And at this point, at the age 14 to 16, we hope the children themselves, depending on their cognitive ability, are taking more ownership of their both their catheters and their bowel washouts, and also depending on their dexterity and ability to do so. But what we would like for them is that they understand a lot of what is going on with their care. If they go into adult services, they are able to discuss with their adult urologist and their adult CNSs what has been happening with them throughout their pediatric services, how many catheters they do a day, what their catheters are, and what care they require. It's really to empower them to feel that they're ready for adult services. So in this clinic, we would do a further UD. So we have a full workup done for our children prior to being transitioned into adult services. We would do a renal ultrasound again, pre their MDT clinic. They're seen by our urologist and the clinical nurse specialist, and any changes made to their, depending on their findings of the above tests are made. But really looking again at trying to make plans to achieve social conscience. Our bladder diaries are reviewed and issues discussed. We would discuss a lot of the issues even at the 12 to 14 stage, but particularly the 14 to 16 stage with the young adults themselves, and giving them again ownership of the likes of how much fluids they're drinking a day. Are they aware of what their stool output is, and are they aware of how much urine output they have? And pushing it back from the parent, I suppose, away from the parent really towards the child or the young adult, so that they can take ownership of their care more going into adult services. We have ongoing reviews of the child's renal function, both with blood tests and with our renal team. We then a discussion again around the preparation for adult services had with the parents and the child at that clinic. A detailed referral will be sent to an appropriate urologist with a specialist interest in adults in spina bifida. Our children from spina bifida and from a neurosurgical perspective will all be accessing Beaumont Hospital for their neurosurgery care, but their urology care will be both in can be in Beaumont as well. But if it's easier, and for the likes of the children in say Cork, Galway, and Limerick and places, they would go to a urologist in their own area, as it would be easier for them to access the service there. But they would be allowed to access services in Beaumont Hospital too, if that's what the parents and the child have chosen. That's really it. A snapshot really for me for our time with the children in Temple Street. I've just explained to the girls, I actually can't stay, unfortunately, for too much questions at this stage. I have to go on, but I will leave my email address for Niall for you to send on any questions to me, and also he can give you this talk as well. At any time, if anybody needs to email us in Temple Street, we do have what's called an email address for spina bifida services. That again I'll give to Niall, that you can send on to me, both from a parent's perspective and young adults, and obviously nurses and doctors. We endeavour to help answer your questions. I hope that's okay. Yeah. That's all. Thank you very much.
Just wanted to say thank you very much from our perspectives. Thank you from SBHI. Thank you very much for coming on here to talk. I know I'm jumping in there on what Niall was about to say, so just wanted to say a quick thank you before you run off.
Thank you very much.
Oh, that's great. No, I'd just like to thank Maeve a lot as well. And I think Katie, we were saying just going to take a 5-minute break there, maybe just to give people a chance to get a cup of coffee or a glass of water or whatever, and we'll come back then. Is that okay from your end, Katie?
Absolutely perfect. Yeah, 5-minute break for everybody. So we'll be back again at 11:50 on the clock, and we'll start her up.
Brilliant.
Thank you very much, everybody.
Brilliant. That was brilliant. Apologies. I'm unmuted now.
Yeah.
So I don't need to share my screen. Okay.
And then their neurology issues.
You are now speaking. Video kind of hasn't come on. I unmute the video here, so my video light has come on now. So will I start sharing here? Maybe see if I start sharing, and you say entire screen application window. You say to share application window. You were saying, wasn't it? Say entire screen share. So I'm sharing there now. Can you see the screen? My camera's turned on there now, so you should be able to see me. I can see you on the right screen there. So if I say I mute video, again you just go. So I'll try and roll this laptop. So you make Ross.
But it still happens. Yes, so and then what I was going to say to you is it eventually dries up because the body then will realise it's not part of it. Is that something that the vitropanops are just continuously produce? No, so
You make your own presenter. Roz's presenter down. I'll just leave Roz's one. If you just piggyback presenter and I'll just bring without video. So it says I'm now the presenter. Okay, so I'm now speaking. So if I share my screen, will you just let me know if you see it? Okay, I'll say share entire screen. So can you see this now? You see the presentation? You can see that, yeah. There's just no video. No video now. Any video there now? My camera seems to be on, like so, because the light has come on there. I can't see myself, but can you see me? Okay, man, look, we'll just go ahead with the presentation and then I'll say, look, we're going to record a video of the demonstration of the products at the end and we'll send that on at the end. So you can see my screen. So if you want to let me go back in now, and we'll talk from there. So if you want to introduce it there again, and then I'll take off. Okay, thanks a million, Noah.
Hello, everybody. Hello, everybody. Welcome back. We were just trying to work out getting the video and getting a few things sorted and allow you also have a little break. So we're back again now, still minus video, but Niall will explain what we'll do at this stage and I'll let him take over here now. So thank you very much, Niall.
So that's perfect. Lovely. Thanks, everybody. Just from, I suppose, a video perspective, we're just having technical issues with Zoho on the video aspect. So I know you can see my screen okay, but just from a video perspective, what we'll do at the end is myself and Roz, after we've gone through everything ISE perspective and product perspective, we're just going to do a short video ourselves, recording demonstration of the products, and then we'll send that on to you at the end with the presentation and stuff like that, with the recorded version of the presentation. So you'll be able to see a demonstration of the products working then as well. So we'll send that on at the end. So it'll be the same thing, it just won't be as interactive with the products here now. So thanks again for joining us. I'm just going to talk you through today with Roz just about our ISE product offering from Braun's perspective. And then again at the end, as I was saying, we'll send you on a video of the demonstration with the products after. So I'll just talk to you about our product offering, then Roz is going to speak then at the end about more clinical service we have to back up the products as well. So just moving on from there. So I suppose just a bit of an introduction. First of all, I suppose what is ISE? What is intermittent self-catheterization? And so, look, I'm sure most of you are aware what this is today, but I suppose it's just the passing of a small hollow tube, known as a catheter, into the bladder in order to drain urine and remove it immediately after draining is ceased. Once educated correctly, it can be performed by the individual or by a parent or carer. So some people, again, every patient is different, every end user is different. Some people might have to self-catheterize once or twice a day, however, other people might have to catheterize up to every 4 to 6 hours. And again, it can vary based on each end user. Catheters all come in different sizes, lengths and types, as you're aware. We'll talk through the different products we have on the market as well, and the different sizes, lengths and types that they come into. I suppose just a couple of the end users that do partake in ISC for themselves. So I suppose it's quite interesting. An awful lot of people, and far more people than you think, do ISC. We know a lot of people often think it's just themselves, or they're one of the only few, but far more people do it than you might imagine. Obviously, there's spinal bifida patients with neurogenic bladders, same as MS patients. You have your spinal cord injury patients that may have been involved in an accident. You have a lot of males as well that have enlarged prostates, more often people with just overactive bladders. So I suppose just a couple of advantages of ISC before we get into kind of more of the product offerings as well. So obviously UTI reduction, so urinary tract infection reduction. So with very good technique and frequency of use, again, once you've been educated on good technique, it greatly reduces urinary tract infections. Kidneys as well, so there's a great benefit on kidneys in that it decreases risks of any kidney damage, so reduces the effect of any leftover urine going back into the kidneys from the bladder over time. So again, reducing any risk of any bacteria forming or any other further infections developing there. From psychosocial aspect as well, so you've reduced risk of any urinary leakage. So again, it's massive here in that it improves patients' overall quality of life and independence. So they'd be far more comfortable going out in public, knowing that they can catheterize in their own time in the bathroom or whatever it may be when they're out in public. The more bladder control, as mentioned above, and complete emptying, and a lot of catheters nowadays, as you see, they're very discreet and very convenient. So there's no effect on the social aspect for patients out in public. Obviously, relationships and sexuality is another big thing here as well. So it allows easier and more spontaneous sexual relationships with your partner. So I suppose this is a big thing, in that you don't have the added concern with any indwelling catheters or anything like that might hinder your social activities. So I suppose then just briefly to touch on, I suppose, a few of the reasons for ISC. So there are many reasons why people cannot pass urine voluntary. Obviously, it could be a condition you're born with as a result of surgery, nerve damage or spinal injury. As we kind of previously mentioned, injury can happen in any way and can affect your ability to urinate properly. Bladder muscles may be too loose, or you may have a valve that is too tight, or as mentioned as well, urethral strictures. So often the case with males, you can have an enlarged prostate, and they can be often quite difficult to catheterize. So intermittent catheterization is the most effective way of managing incomplete emptying and to ensure there's no residual, i.e. no leftover urine left in the bladder. Then just briefly, I suppose, spina bifida and the bladder. Right, so children born with spina bifida are almost always found to have a neurogenic bladder, because nerves in the spinal cord that control the bladder did not form properly. So as we were saying, have a neurogenic bladder. So this means that the bladder will have trouble storing urine, emptying, and often, a lot of cases, you can often have issues with both storing and emptying both together at the same time. This will almost always require lifelong ISC to protect your kidneys and prevent recurrent UTIs. So some children may often require surgery as well. But I suppose good bladder management should include, so initially it's key to get a referral to a urologist, get your urologist to deal with it first. Access a continence advisor, and we'll touch base with Roz we'll touch base in further detail on that and what we offer from a clinical perspective there as well. Regular kidney function tests as well, and this might include urodynamics testing as well, and then the ability to recognize UTIs when they occur as well, and how to deal with them is very important as well. So then this kind of brings us nicely on then to the ISC products. So we as Braun offer a full range of pediatric, adult, as well as male and female intermittent catheters. Our product portfolio is called Actrine, which I'm sure a lot of you have probably know in today's market. I suppose we can teach patients how to use the products in their own home and clinics in the community once they've been seen by a urologist and we've received a referral. So again, that's where Roz will come in again. Also as well, in a lot of urology and outpatient departments within the hospital setting, we often liaise with a lot of clinical nurse specialists. I know a lot of you are on the call today as well, and we educate yourselves on all our product offerings and our range of products, and then we can support the person for these patients then further as well. I suppose the last point there as well, which is quite important, especially in today's market, is all our catheter range and all the sizes. We'll go through that again down below. You see the full range of the different sizes we have. So all our intermittent catheter range are available on the GMS, so they're fully covered on the medical card as well, which is obviously quite important. So that just brings us on nicely then to our Actrine portfolio itself. So kind of broken it down into what we kind of call it the Actrine DNA. So 3 kind of different parts here, and then we'll talk about the product specifically after point 2 there as well as we go down. So firstly, I suppose it's patient safety. So I suppose this is obviously paramount in today's market. So I suppose the key factors here as well are its unique lubrication and the catheter material, what it's made of. It's made of TPO, which we'll touch base on down below. A few of its key features as well, which also make it very safe for patients, is its non-traumatic eyes and non-touch technique catheters as well. Then just on patient autonomy, we'll just briefly touch on how it's ready and easy to use, ergonomic connector, and then I suppose then after point 2 then I'll talk about the catheters themselves with Roz, and we'll create a short video and we'll send that on to you as well. And then finally then we'll speak about the low environmental impact that our catheters have today, which is obviously becoming more and more important as we move forward. So firstly here, your patient safety. So the first point here is its unique lubrication formula. So there's a good few pointers on this that I can touch on that might be of interest to you. So firstly, the lubrication itself is composed of glycerin and water. So it's 80-20, so 80 glycerin to 20 water. So the big thing here is that there's no mess, no splash. It comes pre-lubricated. So it's pre-lubricated with your glycerin water mix. So it's made of vegetable material, and it's GMO free and pesticide free. So there's no water management. So you don't need to wet it in any form or shape before you use it. It comes pre-lubricated and it's ready to use. Again, water control, so no drying out. So this is another big thing with the Actrine range as well. So it stays moist and lubricated for up to 60 minutes after opening. Now, obviously, we recommend once you open your catheter, you use it straight away. However, it does stay lubricated for up to 60 minutes. I know a lot of other catheters often can dry out after 10 minutes, so it does hold its moisture for quite a long time, which is great. I suppose just the image there in the top right I suppose it's to show the aspect of a dried out desert kind of thing, which obviously it wouldn't be very safe to navigate. So your 60 minutes does give it an extra added feature. Next point here on the lubrication is the bacteriostatic effect. So without going into too much, I suppose, detail on this and boring you too much on the biology side of things, but basically the lubrication as well creates a bacteriostatic medium. So that basically just means that bacteria will not develop over time. So it's very safe as well. So it reduces any bacteria formation while you're self-catheterizing. Well, I know that spinal cord injury cases, a lot of the profile of patients that unfortunately are involved in spinal cord injury cases, majority of them, 80% in actual fact, are male, ranging generally from 29 years of age to 41 years of age. Obviously, a lot of this is the key age bracket where a lot of people have future family plans and projects. And I suppose it's massive that they still want to have families. So they need catheters available to them which have safety evidence to back them up. So the good thing with Actrine again, it comes back to the 80-20 lubrication on the catheter, is that it has no spermicide effect on sperm whatsoever. There's no interference of the lubricant in urine analysis results either, and there's no residue left in the urethra after catheterization, which is obviously great. So it has no effect on no spermicide effect for young males moving forward. So again, that just shows, like as mentioned, patient could be catheterizing up to 6 times a day. So you want to be sure that the safety evidence protecting their future family projects for their kids in future as well. Then this is the final point on the lubrication side of things. So it's resistant to extreme temperatures as well. So I know obviously in Ireland we're not really, we don't really get mass extreme temperatures, but just I suppose it's a good point to know as well, depending on where you're storing your catheters, that it is resistant to extreme temperatures from -20 to plus 55 degrees Celsius. So it's just another point to note that you needn't worry about the lubrication being affected in any way prior to use once you've stored it. Then this brings us on to our next point on the catheter material. So what the catheters are made of itself. So it's made of TPO, bit of a mouthful, but it's made of thermoplastic polyolefin. So basically we just call it TPO. So the big thing with TPO is that it's both latex and PVC free. And which basically means that it's chemically resistant and it doesn't contain plasticizers, which, as I'll touch on, obviously with the environment in today's day and age, it's great because it reduces, I suppose, its carbon footprint on the environment today. Then it's non-traumatic eyes. So all the Actarine range have non-traumatic eyes. So the big thing there is no long-term irritation with continued use. You said obviously patients catheterizing numerous times a day. You don't want to cause any effect on the urethra in any sort of way or cause any irritation. So the eyes are also shaped and they're designed for optimal urine drainage. So as you can see there from the photos, you can see there's a cross-section view, a front view, and a side view on the right-hand side. So they're often optimally located at the top of the catheter. Sorry. So they're quite easy to drain urine as well. So that's a big thing here. No sharp edges and smooth insertion for patients with this lubrication too. So then I suppose the next point is the no touch technique. So I suppose particularly in today's day and age, in today's environment, for patient safety, especially with COVID and everything going on now, it's another big factor with ourselves. Well, obviously we can't demonstrate here in video, but myself and Roz will put a little video together at the end thanks Roz, just to show you exactly how to catheterize with them. And Roz is very strong in that perspective, so that'll be very informative for you. So we'll send that on at the end again. But just basically limits the risk of any infection, and it's better overall hygiene as well, which there's a few different ways I'll explain to you in a while on the different non-touch techniques. So then your patient autonomy. So again, ready and easy to use catheters and ergonomic connectors. So as you can see here, they're easy opening. So as we'll describe, so any patient maybe with poor dexterity, as you can see on the picture there on the right hand side, there's a little eyelet kind of inlet in the catheter where you can put your thumb in and just use the force and pressure of your thumb to open fully. That'll open the top of the catheter, and then you're able to pull it down and without touching the catheter, you'll be able to pull it down and insert it as needs be. Also the little kind of slits you can see on the top left hand side there, the catheter, and there you can see it on the right hand side one where the purple arrows are pointing towards. You can tear them off quite easy. It's easy grip, and the catheter can be opened with one finger there as well. So they're enlarged pre-cuts and they're easy to tear off. So just making it as easy as possible for patients. Here's the ergonomic connector. So kind of, as myself and Roz will touch on later, you can see, but it's kind of winged there, as you can see on the right hand corner. So it's easy to grip and it's easy hold. So when you are inserting it, you can get a good grip on the catheter. It's easy to use basically for patients. It's a universal connector as well, and it's color coded, as you can see at the bottom, based on all the different CH sizes. They're all color coded as well, so it just makes easy use for patients, so they might find it easier to kind of remember based on color what size they used last time or what they'd like to move up to maybe. So that brings us on to the portfolio itself. So I'll just describe to you kind of as best I can, kind of without a demonstration as such, until later on when you see the video, how to use the catheters itself. So the Actarine mini range, so this is our female range. So on the right hand side, you can see the mini cat. So anything with ourselves that says set beside it, set just means with bag attached. So anything, could be it the mini range, or when I move on to the highlight range, anything that highlight say set or mini set. Set just means bag, so just to make it simple for people. So right hand side is just our mini cat, and then on the left hand side there is the mini set with the bag attached. So I'll just go through a few of the different features and benefits of the product here now. There you can see it's kind of quite aesthetic for patients as well, and it can be quite hidden as well. For patients, they can put in a back pocket, or as well as that, as you see here, they all come with a discreet pouch as well. So another kind of way of remembering is, we often say as well, so after a mini cat on your left, the mini set on the right, so cat to stay and set to go. So obviously with a bag attached, so you can bring it out with you in public. So again, they're very straightforward to use. They're ready to use, as I previously mentioned, with the lubrication. No water, no mess, no splash. So they come pre-lubricated, stay lubricated for up to 60 minutes. They're the lightest weight product on the market at the minute, and they're quite easy to carry. Low profile products, and they're very discreet in your pocket. So again, you can hide them in your handbag. A lot of people use the discreet pouch, which on the next slide you'll see. Come down to there. Sorry, but you come with a discreet pouch, so they can often be discarded kind of as sunglasses or whatever like that. If any end users are conscious of anything like that, and they can be discarded in your handbag in that kind of way. As well as that, they're 9 centimeters in length, so it gives there's quite a bit to play with there for end users as well. So they're PVC free, DEHP free as well. As I said, this is kind of just reiterating all the previous points. Ready to use, pre-lubricated, stay lubricated up to an hour after use. There you can see the third photo down, the non-traumatic eyes as well, and highly positioned for a better drainage. And there you go. You can see again the winged kind of connector there at the top of it as well on the bottom photo. So here's kind of an example of how you open it. So you just kind of tear the bottom there where you can see it's torn apart. So you just open it like so, and again, you don't have to touch the catheter at all. You just hold on to the wing connector of it at the bottom and insert then as need be. So again, just for, I suppose, safety aspects as well, you're not touching the catheter in any way. So that brings us on then to our mini set. So the product features of the mini set. So the mini set, again, this is just with bag attached, and there you can see the discreet pouch I was saying to you on the left hand side there. So each box of catheters is 30 in a pack, each of them come with one discreet pouch as well. So that's where you can put your catheter to make it discreet as sunglasses, or whatever the patient is comfortable with. So again, the mini set has the exact same catheter properties as the mini cat. The only kind of added benefits here obviously are you have your bag attached, and the bag itself has an anti-reflux valve to avoid any leakages there, as you can see kind of on the top right hand side. There's an easy tear off bag on the top left for emptying, and it holds up to 700 milliliters as well of urine. So it's easy to read as well, and it's very aesthetic for females as well. And I suppose the color pink as well makes it a bit easier to follow it on the white packaging. So here you go. There's just an example of the box there that they come in, a 30 pack there on the right hand side, and with a pouch attached, and they're the lightest weight product on the market at the minute as well. So I know that's handy for people going out and about as well, that it's not an extra kind of something else extra weighing you down when you're going out and about. Oh, there you go, lightest weight set, low profile set there as well. And I suppose for traveling as well, very handy in that aspect as well. When you're traveling, quite light, so there's no extra weight on your luggage or anything like that as well, and they're easy to carry around with you. So here you can see as well. So I'll just briefly, the mini cat comes in a size 10, 12, 14, as you see. Actually, we have a new product now as well, which comes in a size 8. So Roz is just going to briefly mention that to you about the size 8 catheter and how it can be used with kind of patients that she's seen in her own clinical setting. Now, I know she's going to demonstrate here for you, but she's just briefly going to mention it to you, and how most find it for the patients might find it beneficial.
Hi there. Yeah, it's just to let you know that with our mini cath, we, as Niall has just said there, it comes in the size 10, 12 and 14. But we, Braun now have it in a new size, which is a size 8. And as Maeve had mentioned earlier on, that
anything from birth, they would use maybe a size 6 to a size 8, depending on the child. And then from approximately 12 weeks, so 3 months onwards, mum or dad or carer or whoever is looking after the baby would use the size 8 catheter. It's the exact same aesthetics as the size 10, 12, 14, only that it's a smaller size. So the way that they would generally use that, as what Maeve had explained to us earlier on, is that mum or carer would basically use the catheter, insert it into the baby on an average of 6 times, 5 to 6 times a day, and then they would just let the urine flow into the nappy, and then they would just change the nappy accordingly. So it's just nice to have the access to a smaller range of catheters. So Actrine then has a good array of size of catheters for children from birth right the way up to adulthood.
Great, yeah. Thanks a million, Roz. Just give you a brief background as well into the size 8, so thanks a million, Roz. And then the mini set then as well comes in a size 10, 12 and 14. So they're the codes as well. So if anyone needs any details on the codes or ordering details, myself and Roz will share our email addresses and contact details with you at the end. So feel free to just reach out and we can share all the required details with you. Yeah, so that brings us on. So that's your main 2 female catheters. So I suppose that brings us on then to our Actrine highlight range. So the highlight range comes in both the highlight cat and a highlight set. As you can see here, so the highlight cat comes in both male and female, and the highlight set comes in one size, but can be used for male and female too. So just to give you a brief overview here, so the catheter is, you can see the highlight cats on the left hand side, and the set, again, set just means with a bag. So the highlight cats on the left hand side. So the male is the top one there on the 2 photos you can see. So that's 41 centimeters in length, and that is comes in 2 tips as well. So you have your straight Nelaton tip, and then you have a Teeman tip as well, which is another photo on the next slide, which will make it a bit clearer for you. And then you have your female one there as well, which is 20 centimeters in length. So that's the bottom photo there as well. So that patients would typically position themselves to drain in over the toilet or the urinal. So there's no kind of there's no bag attached here. So often it can be more across the community. It's often more widely used. Then you have your set here, so your bag attached. So this is obviously can be used away from the toilet or outside the restroom. So it's quite handy, obviously, for patients over a wheelchair or a bed if need be. You have your bag attached so they can use them straight away there. So again, this just comes in one size. This is slightly different to the catheter, to the highlight cat itself without a bag. This just comes in one size, 37 centimeters. And again, it can be used for male or female, but predominantly, I suppose, more so male. So there, just describing to you the 2 catheter tips. So you have your Nelaton and your Teeman tip. So there's the top one there is your Nelaton, so that's straight, just straight. And again, that's female and male. So the bottom one there is your Teeman tip. So it's kind of curved at the top, as you can see, with an olive tip. So it's often used for any patients that are kind of hard to catheterize or having a little bit of difficulty. Often the Teeman tip comes in very handy here. And as well as that, maybe for a lot of males as well, with obviously, which you know yourself, a large prostate or anything like that, can be often used here. So Teeman tip is purely male. So just, I suppose, brief overview again, highlight cat. It has the very same features as all our catheters, in that it's PVC free and DHP free as well. It's non-traumatic eyes, so it has very smooth bladder drainage. Pre-lubricated, as mentioned, with the glycerin and water, ready to use. Again, there's no need for you to lubricate it yourself. They come pre-lubricated. And again, as I'll show you on the next slide, there's plenty of different openings for them. So they're designed equally for patients with good and reduced dexterity. So again, I'll show you the 2 options to open it now below, and it's a foldable product again for more discretion, so you can keep it folded in your pocket when you go out for a day in your suit jacket for the males, or back pocket for females as well, or whatever it may be. There's no problem. There are the different sizes I was mentioning to you on it there. So with your highlight cat, so that's without the bag, that's your male ones. comes 41 centimeters Nelaton and Teeman tip, and your female is just 20 centimeters Nelaton. Obviously, females don't use your Teeman tip, and obviously you've your adult and pediatric. So here, myself and Roz in the video we do for you, we'll just demonstrate exactly how to do it. But you can see your different openings here. So opening at point A, so and you can see the two hands there in the top right picture. So low dexterity. So this would be for patients that have poor dexterity or whatever it might be. So just insert your thumb into the kind of little inlet opening, open it as you go, and then you can use your accordion non-touch technique. So as you see there, the green line going across. So once you've opened the top there, you'll be able to just slide it down and insert the catheter as need be without touching the catheter in any way. Alternatively, you can open it at point B and opening at 1 there, and then see where it says movable no touch on the top left. You just slide that up and down. There's a picture explaining on the next slide too. So again, there are your two non-touch techniques. Alternatively, you can just open it at point 1 and without touching it, just hold the connector at the bottom and insert it as need be. So here you go. So these are the two options I was explaining to you. So there you can see, so the top photo, so that's if you just tear off at opening at A there. So if you just tear across at point A or open it there for the low dexterity mark, you'll end up like the first photo there. So again, you just pull down the sheet as you go, and you don't touch any part of the catheter and insert. Or alternatively, the bottom photo there, that just shows you how if you tear off at opening point A and point B, you can just use the movable sheet to go up and down as you please. But again, we'll explain that to you in more detail in the video, but that should kind of show you briefly there. So there's what I was saying to you about the catheter just being foldable and discreet. So again, males can put it into their jacket, can fold it up like so, and they do all come with a discreet pouch as well, like the mini cats and mini sets, they come with a discreet pouch as well. So again, males can put it in a pouch either as well, there's no problem. As you can see there, there's the pouch. We also provide stickers. I suppose these would be kind of more for kind of in the hospital environment, but basically just for further aseptic technique, you can stick a sticker kind of while using your sterile gloves onto a cupboard or whatever it may be in your clinic, and you can just take the catheter out, as you can see described there in the photo, and insert if need be too. So here are the different, again, the highlight cats, so the ordering information on it, so the different sizes. So as you can see on the left-hand side, so they're the male highlight cats, so that's it in 41 centimeters, Nelaton and Teeman tip, and they're the different sizes. So again, come from CH8 up to 16 in both, and they're all covered on the medical card as well. And then on the right-hand side, your female Nelaton 20 centimeters, they come from a size 6 to 16, and they're all covered on the medical card as well. So now just the set. So this is the Actarine highlight set. So just an overview here. Again, this is an all-in-one concept. So again, anything with set, and not to reiterate myself, but anything with set just means bag attached. And again, they can be folded into a compact size. So the different kind of component here, I'll get them all for you. So again, you have your different opening options as mentioned with the highlight cat. So you have your 3 options there to open, and they can be adapted to each application as needed, or based on the patient's requirements. So at point A, obviously you can open it if you pour dexterity, or just open the slit there, which you can see at point A, or open it at point B and point C and just move your sheet up and down. Again, like the mini set, there's a non-return valve, so this avoids any leakage obviously during storage. And the difference, I suppose, with the highlight set is that it holds up to a litre, so it can hold, I suppose, 300 more mils than the mini set. And again, this is green in colour, so it's clear and visible, graduated scale for patients to see quite easy. And then you have your easy tear option open on the top left-hand corner there as well, to empty the bag. So I suppose the highlight set, so again, it's foldable, very lightweight and low profile packaging, so it's kind of very handy for patients as well. And there's just a pouch again that it can be carried around with. And here are the ordering information. So these are the sizes that the highlight set comes in. So the Teeman comes from size 14 to 18, and the Nelaton from 10 to 14. And these are both 37 centimeters. But again, any of these ordering details or codes or any queries along those lines, you can just get in touch with myself, and we can touch base with you there, no problem. So that's kind of the range of products we offer. So I suppose finally, just the last point to kind of touch on the whole kind of actine DNA aspect side of things, will be the low environmental impact of our catheters, and how we have a positive effect on the environment in today's day and age. So I know this is quite an important point for a lot of people today. So I suppose very environmentally friendly. As mentioned, PVC and DHP free, and natural rubber latex. So it's made of TPO, as I was saying to you, rather than PVC. So it requires 30% less material to make. It is recyclable when incinerated. If it is a case that it's incinerated, and water and the packaging just turns to water vapor and carbon dioxide. So there's far less waste than I know what maybe other products are available on the market. I suppose there's just a photo and a few more facts to kind of back it up after as well. I suppose often with Act Green, we often say Act Green as well. I suppose it's a dreamy landscape, but as you'll see in a few points I have on the next slide, I think there's quite a reality that someday the oceans will actually end up like that if we're not careful and we don't act on behalf of the environment quite soon. See here, in 2050, oceans will have more plastic than fish, if something doesn't drastically change, which is obviously quite a worrying statistic and worrying trend. However, there's just a few more points kind of that might hit home a bit more with you as well. There's just 10 tons of plastic are produced every second in the world today. And 1 ton ends up in the sea every 2 seconds. So I suppose that just gives you kind of an insight into the plastic and the effect that it's having on the environment. I know a lot of people are doing great work around seas and oceans at that, picking up plastic, but a lot of it, obviously, there's still far more out there. Then just, I suppose, where I'm going with this is, I suppose, in relation to ISC and kind of the packaging that is involved in a lot of intermittent catheters today. Because one ISC patient often can equate to, say, 5 catheterizations a day. That adds up to 1,825 catheterizations per year. And in the US alone, there's 1.5 million catheters used every day, which is the equivalent of more than 26,000 cars per year. So obviously there's a lot of plastic associated with a lot of intermittent catheters in today's day and age. I know a lot of catheters that are available. There's an awful lot of catheters out there. I suppose, so I can be Braun as well. There's great options for people there today. But I do know a lot of catheters do have a lot of aluminium and hard plastic associated with them. So I suppose it's just to be conscious of it yourselves and be aware that just I suppose be careful with your recycling and whatnot. It would be amazing if we had a catheter and used a catheter that helped reduce this impact on our planet. So I suppose this is where we try to act as green as possible. So just to kind of, with the Act Green portfolio, I suppose, just to put it into perspective a small bit for you, it's a catheter with the most minimalistic design and packaging material to reduce environmental impact in today's environment, in today's marketplace. So there's no aluminium at all, there's no rigid plastic. All the packaging is actually recyclable. It's just the catheter itself that you need to put in the bin itself. It is the lightest product for improved waste management. So the Act Green, so take the Highlight Cat, for example, and that's 9.7 grams. And I know the equivalent kind of product will be up to 20.8 grams. It is very environmentally friendly. As mentioned, the catheter material is TPO, made of TPO and PVC and DEHP free. And the film protects the catheter before catheterization and allows aseptic use during catheterization. So I suppose that's just another component of its waste management there. So I suppose just to kind of put into perspective, I suppose we kind of often compare your catheter use to kind of bathroom waste management. So if you look at the weight of a catheter, so if you look at one of the weights of the Act Green Highlight Cat, for example, and the top left corner there, it's 49 grams. And that's kind of the equivalent weight of, say, 2 packs of cotton swabs that you might have in your toilet at home. So I know other catheters can weigh up to 104 grams of the equivalent, and that's the equivalent of up to 5 packs of cotton swabs. And then the set there on the right hand side, 80 grams, is the equivalent, is the weight of a Highlight set, and that's the equivalent of 10 disposable shavers. And I know the equivalent weight in the market is 193 grams, and that's 24 disposable shavers. So I suppose just if you're looking at kind of trying to reduce your impact on the environment over, I suppose, the weight of a catheter over 1 year. So if you use a highlight cath, you'll save the equivalent, I suppose, of 2 years of accumulated bathroom waste, and a set then you'd save the equivalent of 4 years of accumulated bathroom waste. So sometimes I know it's a different kind of comparison, but it's sometimes a way of describing kind of the waste that you'd save and the impact you're having on the environment overall by acting as green as possible. So that's just further tipping home on the point I was already mentioned there, and the TPO latex free, PVC free film can be recyclable, and there just on the right hand side you'll see if it is incinerated, the plastic material will not release any dioxin or other toxin compounds into the environment. So I suppose it's just having a lower carbon footprint wherever possible in today's day and age is obviously quite important. So I suppose just your opportunity, I suppose, to help decrease the ocean pollution. It's not often you get a chance to do that. So I suppose wherever possible, it's nice to use the lightest product available for waste management, materials that have a reduced environmental impact, and a single multifunction material reduces the number of components. So I suppose that's what's kind of important in today's day and age. So look, I suppose that brings an end to what I was kind of just going to mention to you. I'm giving you a background on, I suppose, the DNA of Actrine and the 3 different pointers I was mentioning on it there, and an overview of the products itself. So look, again, thanks a million for your time today. I'll pass you on to Roz now, who will talk kind of through our clinical service offering to back up the products that we have on offer and the features of the products. She'll talk further through what Roz does for us from a clinical perspective. And then myself and Roz will put a short video together for you, just demonstrating the products for you in a bit more detail, and then we'll send it on to anyone that would like to see that. So thanks a million, and I will pass you over to Roz now.
Thanks, Niall. Hi there, my name is Roz, and I'm one of the clinical nurses working with Braun. This is just giving you, it's only a couple of slides here, just to give you an overall view of my background, I guess, and the offering that Braun provide from a clinical perspective. So I've 13 years overall dealing with urology patients, and really what I do is I both teach and educate people in relation to urology and stoma. So the way we work it from a clinical perspective is that with Braun, we obviously are very passionate about providing excellent support to our end users, and that's my aim. So as a nurse for over 20 years, this is what I do. This is my forte, and for me, for both patients and family included, teaching them and giving them an understanding and knowing that they're very educated on the products that they have chosen to use is paramount to me. So I also then would give ongoing follow-up and support with it. As you've heard there, Niall has given an excellent overview on the different types of catheters that we provide. And unfortunately, the computer didn't go our way, but myself and Niall will be happy to make a short video, and it'll just relate all what we've spoke about to the actual video, and we can just talk through it. It'll be a couple of minutes long. So our also just to let you know about our clinical service is paramount to all patients who require support and advice on ISC related topics. So from that point of view, from me with Braun, what I offer is we do pop-up clinics to support and educate on patients with all urology issues. So anybody that requires or that needs to use our products, I'm there to help them, regardless any big or small issues that you have. So as Niall had already said before, what we do is we get referrals from our clinical nurse specialists throughout the country. Some people just require a phone call for support and education, and others then will use our pop-up clinics, which really prove to be work out very well and very beneficial to our end users. But unfortunately, due to our current circumstances with COVID-19, we are unable to have the face-to-face support, to give the face-to-face support to our patients, but we don't want to stop it. So we do run clinics virtually, and all our clinical nurse specialists and consultants around the country are very aware of this. And if they feel that patients need this further follow-on, then they will refer on to me. So it is our goal to get these clinics back up and running, and that is really what I want. I'm your typical nurse. I want to see the patient face to face, and I feel that any issues that you may have, I think, can always be resolved when you're in the room of a nurse specialist. So as I explained to you there about the referrals, if you do have any concerns, or if you feel that this is something that you will benefit from, as we know all our nurses in the hospitals are extremely busy at the moment, but this could be something that you might benefit from. So please feel free to ask. We will leave all our information, or by all means, Maeve has left an email for spina bifida that she is more than happy for you to email in as well, any of the information. So thank you very much for that. I'll just pass you back now just to end it.
Yeah, lovely, that's great. Thanks a million to Katie and Hazel as well from Spina Bifida Ireland as well, for allowing us the opportunity to speak today. Thanks very much, Roz, for those insights. And again, thanks to Maeve from Temple Street for joining us today as well and sharing her insights from Spina Bifida patients' perspective as well. So look, thanks a million. All our details are there on the screen. My email and number there as well. And Maeve asked us to share her email as well with us, so I can shout that out to you there now for anyone that might want to take it down and drop her an email. It's spina.bifida@cuh.ie. So that's spina.bifida@cuh.ie. So you can drop her an email on that for anything you need, and it's also on their website also. If you type in Temple Street, you'll find that website, or you'll find that email on their website as well. If you have any questions for Maeve. But aside from that, if anyone has any questions for ourselves, feel free to shout away, and myself and Roz will be happy to answer any of your queries.
Now, two questions have actually come in. The first question, is it possible to have samples sent to me? That came in from somebody.
Yes, Katie, it's absolutely, that's no problem. So yeah, we can organise that. That's absolutely fine.
Yeah.
Perfect. Then the second question was aimed towards Roz. And do you educate home care staff in clean intermittent catheterisation?
So as I've said there, in relation to if it's a home care group, what we can do is, obviously we're confined at the moment and we're quite restricted, but what we can do is we can do some form of a face-to-face if the setup is right. The other thing that we could do is we could do like a FaceTime with the patient if that suits as well. But the support is definitely there, so it depends. Everybody's different, so it depends on their setup and what way that works. If it's for actual carers, then we can set up something like this, a webinar, and it will be done with a video on.
Perfect. That's brilliant. That's brilliant. Thank you very much, Roz. And I just throw it out there. Are there any other questions from people? These just came in as you were speaking.
Yeah.
Yeah. Perfect.
Yeah. I give everybody a few seconds to type in case they're interested. And while people might be typing, I just wanted to say thank you so much for a very interesting presentation, particularly for me around the environmental aspect of it. I thought that was really interesting. I wasn't aware of that with your products. So thank you very much. The all the thing was interesting, but I wasn't aware of that. Now another question has come in. Roz, do you cover South Dublin and Wicklow?
Yeah, so I cover, yes is the answer. I will cover I cover most areas.
But we're hoping to spread our pop-up clinics when we can get them up and running into different areas. And at the moment, we do have our pop-up clinic that is currently on hold at the moment, but our main one is in Tala. So there's South Dublin for you.
Brilliant. And then there was another comment in here, and it's great to see a company so dedicated to being eco-friendly. So that's something I thought as well, and something I learned
it's
from
lovely to
what I
hear.
came in.
Thanks very much.
Yeah, so just want to thank you both. No other questions have come in for the moment, but they might come in an email, and if they do, I will pass on your details. Oh wait, sorry, another question did come in. How do I find out about the pop-up clinics?
So you can drop either myself or Roz an email there. I hope you can see those all right, but you can drop us an email and we'll share all the details of them with you as well.
Yeah, absolutely. And Katie, if there's anybody that's interested or feels that they will that they would like to avail of them, even if it is as a virtual one, if they can touch base back with you, and what I can do is I can just slot them into the next, either if it's a face-to-face or virtual, it's not a problem. As long as they're happy to share their contacts and their details with me, then I can contact them back. But they can even go through you or any of the emails that's here on the page there.
Yeah,
no
or
problem.
any of the family support team with SBHI or Hazel McGill or our health development manager. All of us will ensure that information gets passed on, or we can get that information. So
yeah, that's no problem whatsoever. And I'll just slot them in. It's generally 2 a month. And as I say, at the moment it's virtual, but as soon as I can get the face-to-face back, of course, that would be my plan.
Brilliant.
And if anyone wants, obviously, copy the presentations or anything like that as well, or Maeve's presentation or ourselves, that's no problem as well. Both Maeve and ourselves are happy to share with you as well. So I know, Katie, if you want to, we can send it to yourself and you can share it if needs be. And we can send that on with the video that we're going to do now as well. So that's no problem.
Lovely. And this webinar was recorded, so this will automatically be sent to everybody as well. So they'll get a fine lot of resources. So yeah, that's brilliant.
Keep them busy there.
Absolutely. Plenty learning. Now, so thank you very much again. Really appreciate it. And just want to let everybody know that the webinar that's taking place next week is around My Wellness and Me, and that's being hosted by Amy Doherty, who runs the RAP program for SPHI and in the wider community. The information will be posted on our website and on our Facebook page. So more information on that, and the session is on My Wellness and Me. Okay, My Wellbeing and Me. I beg your pardon. Okay, so thank you very much, everybody. And yeah, I will